specialist talking to a new patient called Jason Riley. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes. So, Mr. Riley, you've been referred to me because of a problem with your knee. Is that correct?
Yes, it's my right knee. It's very painful.
Okay. I've got some information here from your GP who's treated you for bursitis. But can you tell me about how this developed and what's happened so far?
Well, about 2 years ago now, my knee, this knee, swelled up and was really big. It didn't hurt, and it just looked really strange. I'd been on a week's golf holiday in Portugal, and the knee was a bit dodgy all the time I was there. Well, when I got home and the wife saw it, she sent me off to the GP straight away, who said that it was what people used to call housemaid's knee. That caused a few laughs at home, I can tell you. Then I remembered that my mum used to get that in her shoulder. It's really called bursitis, isn't it?
Yes.
But he said not to worry, to rest up a bit and wait and see if it went away. And it did in a few weeks.
Right.
So I was okay for a while. Then about a year ago, I got a new job. I used to be a painter and decorator, but I retrained as a carpet fitter. So I'm on my knees quite a bit. Goes with the job. And after a while, this must be about 6 months ago, the knee swelled up again. It looked really red this time, and I had a sort of dull pain as well that got worse.
Okay.
Also, I felt slightly shivery and feverish. The GP said I probably had an infection and gave me some antibiotics for 10 days or so. That seemed to do the trick, and I felt much better, but the knee was still a bit swollen, and it ached sometimes.
Did you try painkillers?
Oh yeah, after a bit, the doctor suggested ibuprofen, but that always seems to give me a tummy upset, so I stuck to paracetamol. I'm still using them on and off. At work, they put me on to doing things that didn't need a lot of kneeling when I first went back, but only temporarily. And I put ice packs on my knee to bring down the swelling as often as I could, every few hours. I tried to take breaks too. Oh, and my GP suggested some exercises to protect the knee, lying down on my back and raising the leg.
Yes.
Which seems to reduce the aching. In bed, I made sure I slept with a pillow under it to keep it a bit higher up too.
And was your knee still swollen?
Yeah, it was. So then the doctor drained off some of the fluid by sticking in a needle. I remember he said he got 20 millilitres out.
Right.
After that, he suggested that I try some supports in my shoes. I couldn't really see the point of that, but apparently it's to do with your arches, which I guess does affect your knees.
Yes.
Also, he told me to make sure that I have plenty of padding on my knees when I'm at work, and I've been doing that.
Good.
He told me that I should think about losing a good few kilos as well, but I like my food, as you can see, and I haven't made any progress with that so far. But things weren't getting better, so then he started giving me cortisone injections. I've had 3 of those so far.
And what effect did they have?
They really helped. Much less swelling, and the pain's better too. But that's the problem. He now says that with those sorts of drugs, you can't have more than 3 of them in the same knee in a year. I'm up to the limit, and it keeps coming back, so really I'm hoping you'll be able to come up with something better.
Okay. Well, let's have a look, shall we?
Extract 2. Questions 13 to 24. You hear a GP talking to a new patient called Mike Royce. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello? Coming in. You must be Mr. Royce. I understand that you've just signed up with the practice.
Yeah, that's right, Mike Royce. I've joined this practice because my previous GP retired and he suggested I come here.
Right, and I understand you've got an ongoing medical condition you're worried about? Perhaps you'd like to start by telling me about that. How did it start?
Well, I suppose it started out as a really strong pain in my left knee. I think it's called the medial meniscus. Is that right?
Mm-hmm.
It came on whenever I tried to bend the knee more than normal. Then I tripped while climbing some stairs at work, and that seemed to make things worse. I started to get these very tender bumps all over the back of the knee.
Right.
They were very painful, even just lightly touching them. The doctor called them trigger points.
Yeah, that's right. They're called that because pain frequently radiates out from them when touched. And how did that affect you day to day?
Well, I went back to work after a week or so, but I was still having knee problems. I couldn't really squat properly or climb ladders. That's important in my job. I'm a painter, and I'm always having to get into awkward positions. Anyway, I kept going back to my old GP explaining that I still had severe pain whenever I tried to bend my knee. He gave me all these exercises to do, and I tried doing them. I really did. I made sure I did gentle stretches before I did anything more energetic. Everything, really. I tried resting like he told me. I used ice packs when it got sore, but nothing really worked.
Right, I see.
But then the doctor decided I might be suffering from tendinitis, so he sent me for some rehab work in the hospital. That actually did seem to work, at least at first.
But I'm guessing not for long.
Right. The problem came back. I kept telling the doctor that my knee still wasn't healed, but it was actually my physiotherapist in the hospital rather than my old GP who noticed that something was wrong with my muscles. He wouldn't say what it was, but I knew something was up. He was doing myofascial release on my hamstrings, and I was in agony.
Right, so did you go back to your GP?
I did, but he didn't know what I should do about it, so I left feeling completely fed up. That's one of the reasons I decided to come here.
Okay.
I just feel like nobody's taking this seriously. I think it's affected my life in lots of other ways too. The worry's given me insomnia, for one thing. I don't think I have actual depression, but I certainly suffer from constant anxiety about when it's going to flare up.
Is there anything that you're particularly worried you might have?
Well, I've researched this pain I'm getting. To be honest, I'm convinced I've got fibromyalgia, not just some simple muscle problem, because I fit most of the symptoms, and I've had pain absolutely everywhere. Look, I've even kept a pain diary so that I could track what I did that set it off. The weather, if I was working or not, where it was affecting me, what it felt like.
Oh, good.
I figured out from this that it's usually in the same places that I mentioned earlier, plus some newish places too. My shoulders and elbows. And I know that my knee's actually one of the more tender points for it. What do you think?
Look, I must say from what you've told me so far that I'm concerned enough to look into that possibility. So as a next step, we need to get you seen by a rheumatologist. This is a notoriously difficult condition to diagnose, as I'm sure you're aware, because so many of the symptoms overlap with other conditions too.
I won't be happy to be proved right, but I'll certainly be glad to get some answers at long last.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a consultant talking to a woman whose father has just been admitted to hospital. Now read the question.
So we've talked about the various things that might have caused your father to collapse. A lot of times we investigate multiple symptoms so as to rule out any life-threatening conditions.
So it could take some time to get to the bottom of the problem?
Possibly. In the meantime, he's quite stable now, and we're encouraged by the progress that he's making.
Well, I'm glad to hear that. But at least he's not in any great discomfort, is he?
According to the assessment at the bedside by his nurse, his pain is well controlled, and we'll try to keep his sedation at an adequate level until we're ready to begin treatment.
Question 26. You hear a trainee nurse receiving feedback from her tutor about the ward round she's just completed. Now read the question.
How do you feel your ward round went with that patient?
Oh, I really should have told him what I was about to do, rather than just rolling up his sleeve to take his blood pressure.
Yeah, it would have been preferable, but at least you realise.
Thanks.
I think you did your observations really well, though. You checked the patient's details are correct, you put the date in, you timed it correctly, you observed that all your parameters are within normal range, and you did the respiratory rate while you were doing your manual pulse.
Yes, the pulse was quite strong and regular.
And you could have passed that on to reassure the patient too.
Oh.
But you look back at the previous observations, put your signature at the bottom. That's all good.
Thanks, okay.
Question 27. You hear a hospital nurse briefing a colleague about a patient with chronic obstructive pulmonary disease, or COPD. Now read the question.
So who's next?
The patient in bed 12, she had a fall at home about a month ago, but she's otherwise independent with her day-to-day activities. Her falls risk is high given her recent history. She's been assessed by the physio, and she's on a rollator frame to ambulate. Her skin integrity is intact, and she's responded well to all treatment.
Good.
She's on a normal diet. The observations were last done at 6 a.m., and they were stable. Her medications are IV tazocin due at 2 p.m. and prednisone next due at 8 a.m. tomorrow.
Okay.
You need to check with the doctors today whether she'll continue with the IV antibiotics and whether the cannula can be removed. At this stage, they're aiming for discharge in a couple of days' time, pending discharge from the physio and also ceasing IV antibiotics.
Okay, thanks.
Question 28. You hear 2 hospital managers talking about a training session for people who do voluntary work with patients. Now read the question.
So how do you think the volunteer training course went?
Well, we had a reasonable turnout, considering that these people already give up their free time to drive patients to appointments, visit inpatients, all sorts of stuff like that. It's quite a lot to ask. It's a wonder so many managed to fit in the training too.
And they did seem to get something out of it, if the feedback sheets are anything to go by. From my point of view, though, I just wasn't sure whether it went into issues like customer care, confidentiality, that kind of thing, you know, in enough depth.
Well, that's something we can always look into before we roll out any more.
Well, I think we should.
Question 29. You hear a pharmacist talking to a doctor about a patient's medication. Now read the question.
Sorry to bother you, Dr. Baker. I just wanted a quick word about Mrs. Milton's prescription, the one for anti-inflammatories that you gave her after last week's consultation.
Oh, yes, for her osteoarthritis.
Yes, so she's been on them for a week now, 500 milligrams twice daily. The thing is, she's just been into the pharmacy complaining of a headache ever since she started the medication.
Really? Well, that does happen in some patients, but maybe switching her onto a different anti-inflammatory wouldn't be a bad idea.
OK, I'll look into some options and then run them past you later, shall I?
Fine, thanks.
Question 30. You hear a surgeon talking to a member of his team as they are finishing a surgical procedure. Now read the question.
Good, there's no more bleeding. The procedure's finished.
Can we just do the sign-out? How much contrast did we use?
That was 120 mils of Omnipaque, and we did reach a high dose, so I'll have to fill out a high-dose form. I'll do that afterwards. The other thing was that the ultrasound machine was giving us a few problems.
Yeah, I'll have to get the technician on the phone.
Do it now, though, because we'll need it if we're going to get through all our list today.
Do we need to send this patient up to HDU?
Actually, everything was quite straightforward, so I'd say a regular ward bed is fine.
That is the end of Part B. Now, turn over and look at Part C.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now, look at Extract 1. Extract 1, questions 31 to 36. You hear the lecture given by a physician on colectomy surgery. You have 90 seconds to read questions 31 to 36.
Hello, doctor. Please explain to me different types of colectomy surgery.
Well, the surgery to part of or all the colon or the large intestine is called a colectomy, and there are many types of colectomy surgeries. The type of surgery and how much the colon is removed based on the disease and the extent of damage to the large intestine. In the proctocolectomy, the colon is removed along with the rectum. The term procto refers to rectum. With both the colon and the rectum removed, the body will need a new way to dispose of stool. For most people with inflammatory bowel disease, either ulcerative colitis or Crohn's disease, a proctocolectomy also means the creation of an ileostomy. When part of the small intestine is brought through the abdomen to create a stoma, it is called an ileostomy. Therefore, the stool can be passed through the stoma and is received in an ostomy device worn on the outside of the body. The ileostomy can be temporary or permanent. J-pouch surgery is an ileal pouch anal anastomosis, which is done along with proctocolectomy or after proctocolectomy. In this surgery, the last part of the small intestine, called the terminal ileum, is sewn together in the shape of a J and can then hold stool for a period of time, serving like a rectum. Ileoanal anastomosis is done to restore the ability to move stool through the anus. In this surgery, after the rectum and colon are removed, the small intestine is connected directly to the anus. In the total colectomy surgery, entire colon will be removed. Unlike proctocolectomy, the rectum is not removed in this surgery. A total colectomy with partial or complete rectum left in place may be done in certain cases of either Crohn's disease or ulcerative colitis. In a partial colectomy, part of the colon is removed, and it may also sometimes be called a subtotal colectomy. A partial colectomy may be done for certain patients with Crohn's disease, while it is also done to treat colon cancer or diverticulitis. This surgery is never done for the patients with ulcerative colitis, since the disease will often recur in the healthy section of the colon that is left. In hemicolectomy surgery, either the left or the right part of the colon is removed. In a right hemicolectomy, the cecum, ascending colon, and a portion of the transverse colon are removed, along with the appendix is attached to the ascending colon. Whereas in a left hemicolectomy, the descending colon and part of the transverse colon are removed. In this surgery, typically the healthy sections of the colon are connected together. Therefore, an ostomy is not required.
Here in the health report, we cover all sorts of search. The Mediterranean diet, what fat is right for you, how much salt is safe, diets to protect you from diabetes, early death, heart disease, So this next segment is actually a bit perturbing. We're being told that almost all this research is wrong. Yes, John Ioannidis is Professor of Medicine at Stanford University, and he says the scientific approach taken by nutritional researchers is nowhere near rigorous enough, and we have to go back to basics if we're to learn anything significant about how diets impact health.
Thank you for inviting me.
Now, we've had you on lots of times before, talking about various things and demolishing a few iconic areas of health and research. You're arguing that nutritional research needs radical reform. On what basis do you say that?
Well, there's clearly a factory of papers being produced in nutrition epidemiology in particular that don't meet very high standards of credibility. The type of research that is being done in nutritional epidemiology, it's not an issue that there's bad scientists involved in it. You know, maybe excellent scientists are involved in it, but the odds of getting it right are extremely small.
Let's look at that in a moment, but you quote in your paper some really bizarre conclusions that you might come to from if you've believed past nutritional research. Do you want to just tell us some of those bizarre findings and their relation to either longevity or shortened lifespan?
Most of these studies are not experimental. They're not randomized. They're just observing people who report what they eat, and they take that seriously, that this is reflecting exactly what they ate, which is one major assumption. Second, people take these behaviors and these numbers as causal, which means that they look at the numbers and they translate them to an effect of these nutrients or of these foods on mortality. And then they also make another assumption that these risks are applicable to the entire lifespan. So then, let's take a number like 15% relative risk reduction in mortality or 15% increase in survival, which is a typical number that comes out of these studies. And this is the number that is the summary of all the data, for example, on what is the benefit with eating 12 hazelnuts a day. If you translate that to a gain in survival, you take 80 years, you multiply that by 15%. This looks like a 12-year gain in survival just by eating 12 hazelnuts a day, or literally one hazelnut a day would give you one more year of life as a benefit. It's a ridiculous calculation. It is not so, of course. Even if you believe that one of these foods or one of these nutrients or a couple of them may be important, it's impossible to believe that every single food, every single nutrient will have such tremendous benefits or such tremendous risks.
So you get there because of there's multiple levels of unreliability. Is that what it is? That essentially the food diary is unreliable, they're not controlling for other factors such as education and other environmental factors properly, and they all conflate together to give you bizarre results? Is that what's going on?
Exactly. It's a problem at multiple levels. It's an extremely difficult field to study. And it doesn't mean that observational studies, that epidemiological studies get it wrong all the time. In many other fields, the problems are much more straightforward. For example, we know for sure that smoking is killing zillions of people. It will kill 1 billion people in the next century unless we do something. But the effect of smoking is huge. The risk increases 20-fold if someone is smoking for getting lung cancer.
But just to challenge you on that, whilst we're confident in smoking, why are we confident in smoking and not in coffee? Because there have been no randomized controlled trials of getting people to smoke and other people not to smoke. I mean, so that's still on observational studies, is it not?
The major difference with smoking is that the effect is tremendous. We're talking, as I said, of a 20-fold increase in risk of lung cancer, 10-fold increase in cardiovascular disease. Many other diseases have tremendous increase in risk. For each single nutrient, each single things that we eat or drink, the effects, even if you take these studies literally, are much, much, much smaller. And based on what we know from some randomized trials that we have done, the effects are pretty much close to null, if not exactly null. I mean, it's very likely that they're exactly null, which means that it's a complete waste to even try to pursue them any further.
What about...
We cannot really use epidemiology to study a relative risk of 1.01. We can do it to study a relative risk of 20 which is what's the case for smoking.
And just to dissect that out for people don't know the statistics, is that 1.01 is, there's no effect, 1.01 is just tiny, whereas 20, an effect of 20 is 20 times the risk. So 1.01 is just a little bit over what would be normal and probably within normal limits. So what about eating patterns? I mean, you yourself have been involved in trials of the Mediterranean diet.
So I think that eating patterns, in theory, might be able to get you a little bit of that complexity of all these nutrients interacting together. But even those are very difficult, if not impossible, to study within an observational context. Again, you have most of these problems operating. Number one, you need to ask people what type of eating pattern they're following, and responses may be accurate or very often may be very inaccurate, especially if you try to recall what you ate and tell what you're doing. Just try it to yourself and see whether that information would be reliable. The second problem is that you still have extreme complexity among all these nutrients. We have over 200,000 different foods that you can combine in different ways. There's no clear eating pattern that each one of us is following. We follow different eating patterns in different periods of our lives and different days even. And it also changes all the time. If you superimpose the way that we react to all of these chemicals that we digest, our metabolic profile, also our genetic profile might affect how we react. Circumstances, our environment, socioeconomic factors that dictate what we decide to eat or not eat, and what we do or don't do with our life at the same time. It's an extremely complex system.